Greetings to all from Advanced Fertility. Today I'm going to discuss about treatment of poor responders and low AMH and see what all new has been offered in the past few years. So as we are seeing more and more women are coming to us with reduced AMH levels, and we are trying to strategize to see how to optimize their results. So few things that have happened in the past few years are double stimulation or duostim, embryo pooling, and PRP. So we will touch upon these and also discuss the newer stimulation protocols. So when we call poor responders, earlier scientifically there was something called the Bologna Criteria, where 2 out of these 3 criteria had to be fulfilled. One is the age, which should be more than 40, or it should be a previous response of poor response. That means less than 3 eggs were collected, or your tests have shown low ovarian reserve, like your antral follicle count on ultrasound is less than 5, or your AMH is less than 1. So if any of these 2 parameters were there, you were considered in poor ovarian response category. Recently, in the past few years, there is the new definition of low prognosis groups, and it was defined as the Poseidon Criteria. In this, there were some women who did not have less response, who did not have low AMH, and yet produced poor response whenever ovarian stimulation or egg pickup in IVF was done. So the low response women were divided into 4 categories, and this was divided upon age and your AMH levels. For those who don't know what is AMH, it is anti-Mullerian hormone. It is a measure of your ovarian response. And if you have an ovarian response of more than 2 nanograms per ml, you have a very good ovarian response. And if you have it less than 1, you have a poor ovarian response. So group A and group 1 and 2 were those who were either less than 35 or more than 35 with normal ovarian reserve tests, but poor response. They were called the hyporesponders. And 3 and 4 had poor ovarian reserve tests and did not respond well, which was expected. So it was kind of divided into expected and unexpected poor response. So number of regimens were devised to try to help these women. And these included in your IVF protocols, the suppression, which whether you used agonist, antagonist, whether you give androgens, growth hormone, natural cycle, high dose, moderate dose, steroids, coenzyme Q10, acupuncture, holistic medicine, autologous. So when we see that the treatment of any problem in medicines has numerous options, we must immediately understand that we still haven't got the exact treatment. Now, the reason for us not being able to give very high results of pregnancy in women with low AMH or poor response is the belief that there is a fixed number of eggs remaining. And when you have reached the stage of low AMH, there are only fewer eggs remaining, both quantity and sometimes quality, and our results will not be as those with normal AMH. Of course, there is a disclaimer. There are women who are younger, who have single ovary, and their AMH is less, but their response and results will be good. Then expected poor response focused on the stimulation protocol, duo stimulation, and additional supplements like androgens or testosterone, growth hormone, and antioxidants like coenzyme Q10. In unexpected, again, it worked around similar lines. And one of the most important additions in unexpected poor response is increasing your gonadotrophin dose and adding recombinant luteinizing hormone to your stimulation protocol. So as you can see, there are numerous options which we have discussed earlier, and now we will touch upon a few of these in my lecture. So first is the protocols. Now, what is a stimulation protocol? It starts usually from the first or second day of the period, and before that period comes, certain treatment happens so that when the main injections are given for 10, 12 days, the pool of eggs that we get are optimally prepared. So how do we do this preparation for ovarian stimulation? For example, in the first, it is the estrogen priming. That means you just give estrogens in the last few days. Then it is the delayed start. You give estrogen and then you give antagonist. Suppress and then you start later. Then you give something called an agonist. This is our usual long protocol, what we call in daily parlance, long protocol. Means it started on day 21, you've done down regulation, and then you have given the stimulation. Usually you start with a higher level of agonist. Here it is triptorelin, you can give leuprolide, and then you halve the dose. Then in some, you give not only estrogen, here in the first picture, you also add antagonist, and then you start with the stimulation. Now let me go through various stimulations. You will be confused with the different stimulation protocols, and then I'll share my viewpoints on all these numerous minor modifications that are happening. Now there is another novel stimulation in which on day 21, you have given your agonist, then your period has come, you've given letrozole, then you have given FSH injections, you have added LH, you have given antagonist, and then you finally give HCG. Now this group has said, the study was in 2021, very recent, has found good response with this protocol. By good response, we mean good number of oocytes and hopefully good number of grade A embryos and translating into good pregnancy rate. Now, there are these various other flexible short protocols. Now, what does this mean? You will see when you say a short protocol, there is nothing before the period. It all starts from the period. Now, this is the mild stimulation protocol. You give this tablet from the start of the period, third day, and then from the fifth day, you start the gonadotrophins, which are the injections that are given, and then you do and the doses are not very high. So here a little thing about the dose in low AMH or poor responders. It is not higher the better. It is explained by some, and which I am quite, I find it easier to explain similarly, is it is like if you have a large engine of a car, the more petrol you give, the better it will run. So your AMH is your engine, and it's not that, and your gonadotrophin injections, the hormone injections are your petrol. It's not that the more petrol you give, the better your engine is going to work. You have to give adequate petrol for your engine. And the consensus is medium dose injections is fine. So by medium, it usually varies from 225 to 300 international units all total. Some go to 400, 450, 600 is usually stopped all over the world. I really feel that beyond 450, it's of no use. You're just increasing your cost of treatment. Okay, then next is your period, and then you have given your agonist. This is the routine shot protocol. So you did not give it before your period, and then you have added gonadotrophins, mild to moderate dose, and then you've done your HCG. The next one is the flexible shot. You started your agonist. You waited for the follicle to go beyond 5 millimeters, and then you started your gonadotrophins. So this group has said that it's a Chinese group, that the flexible shot is giving us better results. Now we come to the very recent last 3-4 years maximum, 4-5 maybe, of double stimulation. So suddenly what some clinicians found while they were doing, so what happens in a stimulation? You wait for your periods to come, or you start the stimulation then. But then usually they started in the cancer group. Unfortunately, if a girl is diagnosed as malignant cancer, then you need treatment. You need to give chemotherapy, you need to give surgery, you need to remove ovaries sometime, you need to give radiotherapy that's going to damage the ovaries, and she will be deemed infertile forever. So, to help these girls preserve the eggs, some had such advance that you cannot even wait till the next period, which if she's been diagnosed on the 7th day of the period, she'd have to wait whole 21 days. And you cannot sometimes, you have to start treatment because otherwise the malignancy will spread. So for them, people started giving injections, these gonadotrophins, hormone injections, whenever. Some on the 8th day, some on the 10th day, some on the 15th day, some on the 18th day. And lo and behold, they found the ovaries responding. So this huge concept of 40 years that we had, that you have to wait on day 1, day 2, changed. So in these, you have to freeze the eggs or fertilize them with sperm and freeze the embryos and transfer in subsequent cycles. For the cancer patient, it is when they have completed their treatment, and for poor responders, the next or the next. So the mandatory requirement of freeze-all and lack of cost effectiveness data are limitations of this normal approach, of this novel approach. Till date, in malignant patients and patients with advanced age or ovarian reserve, this can be tried. This was a study in 2021. So very recent, is still saying 2020, the luteal phase stimulated derived oocyte increased the cumulative live birth rate per intention to treatment in a single ovarian cycle in patients fulfilling Bologna criteria. What does it mean? Follicle stimulated means when you start in the beginning. Luteal phase is when you start in the middle of the cycle, when the middle of the period, you still haven't got your period. So if you do this and if you do that, your overall pregnancy rate is increasing. The dual stim strategy is promising to manage this thorny population of patients, especially to avoid discontinuation after first failed attempt. So we have to read this study with a little bit of salt, is that it does not mean that the luteal phase has better pregnancy rate, oocytes. It means that for a patient who has done follicles and luteal, she has overall better chances, because the chance that she would do another cycle is less. So here I have a few contentions, and we are in the process of presenting our data, which I will discuss. And but first, just see the duo-stim strategy. So it started, they did it, they gave estrogens, the period in the previous cycle, day 21. Then these periods came. Then they started high dose, 450 units, FSH, LH. Then they gave antagonist when the lead follicle is 14. Then they give agonist trigger. So trigger is the injection that gives the last maturation of the eggs inside the follicles. If you don't give trigger, you will not get matured eggs. The trigger can be HCG injection or agonist injection. So here you give agonist, you do the egg pickup, you wait for 4 days. The lady may bleed or may not bleed, and then you start stimulation again, and then you do agonist trigger, and then you do pickup. Okay. Now, in this study, they definitely found that the overall pregnancy rate and the cumulative live birth rate was almost double in the duo. Interestingly, very few underwent the second stimulation in the other group. So here I have my experience to share. I feel that duo-stim is still in the early phase. We really need to do more studies to say whether, if we have time in our hands, whether duo-stim oocytes, eggs, are better in pregnancy than month-per-month stimulation. And in our center, the second, if we have counseled our patients that you will need 2 to 3 stimulations right in the beginning, the first consultation, this is very high. This is as high as 60 to 70%. So yet we need to conglomerate data to say whether month-per-month stimulation is better or duo-stim is better. Pregnancy rates per patient. Another interesting protocol, Shanghai, by the Chinese, and they have done it, is again, they have used clomiphene. It's an oral drug for stimulation. Letrozole, these are the days that they have given it. Low dose gonadotropin, agonist trigger. And when they've given agonist, they have also given ibuprofen, which is like Brufen or Flexon that we use, apparently for better egg maturation and oocyte retrieval. Then they have given, again, started the gonadotropin, this time the luteal phase at a higher dose, medroxyprogesterone in the last few days, agonist trigger, oocyte retrieval. And then they have seen what is the overall pregnancy rate. This group have found good pregnancy rates in poor responders with the Shanghai protocol. So, appears to be a promising strategy, and like I've mentioned, yet very questions to be answered. Cost-benefit ratio is a very important question to be answered. It has to be validated that, you know, your duo-stim and your month-to-month stimulation, it must take into account that after a gonadotropin releasing hormone trigger, menstruation appears 5 days later. Therefore, it would be necessary to reconsider the term LPS. Very interesting, very interesting. So here, see, when it is your luteal phase, you do not have periods, it's a full month. But when you are doing egg pickup, you are getting periods very soon. So it is almost like you're getting the cycle. And it's not your luteal phase, and it is follicular. For those who are not understanding this technicalities, my apologies. So what this slide is basically saying, that is it really 2 stimulations in the same month, or is it 2 different stimulations actually? So it leads to accumulation of oocytes. So these various studies that are kind of saying, okay, let's do it, let's do it. Now, this is a very interesting SWOT analysis of anything. You have a new thing in medicine or anything in life, you need to do strength, weakness, opportunity, threat analysis, and then decide whether that's good or bad. Now, what are the strength of duostem? Higher number of oocytes and embryos obtained per ovarian cycle. More patients obtaining competent blastocyst. No difference in competence between oocytes in follicular or luteal. Weakness, high number of stimulation cancelled. No randomized control trial study on cost effectiveness study. Freeze-all is mandatory, means you must have a lab and technicians or embryologists, scientists doing very good freezing procedure. Applied only to poor prognosis patients. So already your group of patients on whom you will apply has poor prognosis. What are the opportunities? It might reduce the time to obtain at least one competent embryo. It might be better tolerated from the patients than consecutive follicular stimulating cycle. So this is something which needs to be studied. Will women prefer month-to-month stimulation if time is not the essence? Or would they rather do, day 1, day 15, day 1, day 15? It may reduce dropout, theoretically. It may increase the knowledge regarding the mechanism of follicular recruitment and ovarian physiology. It may increase our scientific knowledge. Threat, cost effectiveness. Increase total gonadotrophin administered. Few biological, gynecological, neonatal evidence for safety. No safety studies. Is the eggs here better, worse than the eggs obtained here? Because finally, what do we want? We want a healthy pregnancy. Right, so much so for duostem, and we have just started doing duostem in a few women who do not have the time. Currently, our belief still is to do month per month stimulation, which is more physiological so far, who do not have time constraints. And our data is yet to be analyzed to see which of these is better. So now you have done duostem, you have done multiple stimulations. Now you need to pool these embryos, right? It's a promising strategy. So you do one cycle, whatever embryos you get, you transfer, or you do one cycle, two cycles, sometimes three cycles of stimulation, means month per month injection. Whatever embryos you get, you freeze, 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 till you get 3 grade A cleavage or where 1 to 2 good blastocysts. Now, this meeting is not about whether cleavage is better in them or blastocyst is better in them. My personal experience is cleavage is better when you do not have too many oocytes. Some say, well, let them extend and at least you know which blastocyst. And my argument to that is that better to put it in the natural environment and give those embryos the best chance rather than putting it in an artificial environment. And whether they didn't go to blastocyst or not, maybe because they were weak, they could not survive the artificial environment, but they would have survived the natural environment. Still open to debate, but now we are talking about collecting these eggs or embryos. So embryo banking with mild ovarian response. Embargo protocol consisted of several cycles of mild stimulation, clomiphene, and then HMG 150, and subjects underwent antagonist protocol. And, in that they said expected, embargo procedure was not efficient in improving the overall clinical outcomes. Now, this study is presented to say, when you do multiple stimulations, you should follow the normal conventional protocol of moderate gonadotrophin stimulation in each cycle to optimize your outcome. And this is what this study has also confirmed. Accumulation of oocytes, a new strategy. In conclusion, results obtained in the current study demonstrate that the accumulation by vitrification is associated with a lower dropout rate, fewer transfer cancellation, higher live birth rate, more cycles with vitrified embryos, higher cumulative live birth rate, which endorses treatment of successful alternative of low response. Now, this group, it's a Spanish group, they have done it, multiple cycle stimulation, and all outcomes were better. And in what they have done is they have frozen, because ICSI, when you freeze eggs or you freeze embryos. So each month, if you freeze embryos, you're doing ICSI every month. And cost per treatment, if you see, for ICSI, it is expensive. So rather than doing ICSI in every cycle, they have done ICSI and the end on frozen oocytes. Now, we kind of believe that anyway, these are poor oocytes, freezing, thawing. We've got good freezing of oocyte rate, but already compromised, rather do ICSI, and embryos have a better survival rate. And cost at the end is not as important as translating into pregnancy, right? So this is an option, but we believe in embryo freezing. Okay, so we've done the best protocols, we've frozen the embryos, we've done the transfer, yet either we are not getting the results, or this lady who has come to us has very, very low AMH. She's still cycling though. And what else can we offer? Now, platelets have certain growth factors. Platelets are substances in our blood. We have red blood cells, white blood cells, platelets in our blood. Platelets have certain chemicals that, if you put into the ovary, may rejuvenate the egg cells or the oocytes and produce good quality oocytes for better pregnancy outcomes. So, how is it done? You take a blood sample, you take reasonable amount of blood sample, 30 to 40 ml. You put it in the centrifuge. There are various ways of separating the platelet-rich plasma. And then you take out that puffy layer which has the platelet-rich plasma, and you inject it into the ovary, usually under ultrasound guidance, usually with the needle that you use for egg pickup under anesthesia. And then you wait from 1 to 3 months to see whether your AMH is changing and to see whether in premature ovarian failures where periods have also gone, sometimes periods start. But there's a big disclaimer to it. It is still very experimental. It should not be taken as a panacea to low AMH. We are still not sure whether it actually helps or not. And whenever we do it with the big consent that we are trying to see whether it's going to help you. And this is all over the world. If anybody is claiming that you do PRP and you'll get good eggs, I think it's wrong. Now, a line about stem cells. According to my knowledge, stem cell in India is still to be done under experimental guidance, ethical clearance from an ethical board, usually directed by government bodies, including the Indian Council of Medical Research. So I don't think we can give stem cells to our patients without coming into a trial. So I don't do stem cells because it takes time to get into a trial. And we have given our paperwork to be considered in a trial for stem cell. So we are doing platelet infusion. In the absence of an overall efficient treatment protocol for poor responders, PRP treatment could be successfully employed as an alternative, effective, safe approach. Even though the treatment for poor responders remains a therapeutic challenge, the usage of intraovarian injection of autologous PRP before IVS brings a glimpse of hope. Right. So what do we do at our center? Counsel. You know that slide where you saw that the first case, first time they stimulated, the second time was only 10-12%. I think that will change if you counsel your patients well as to what you are going to do right in the beginning. And you make it clear that they're going to be at least 2 stimulations. Majority will go for that. Optimize outcome. What does optimization come in? Weight, thyroid, blood sugar, multivitamins, smoking, alcohol. No smoking, no alcohol, multivitamins for 1 to 2 cycles, correct thyroid, correct sugar, weight, optimize as much as possible. 1 to 2 months you can give. You can't wait forever for the weight reduction because time is of essence, really. Yes, in overweight, results are poorer. So women need to know that, but we all know weight loss is a struggle. And not taking women who are obese, I don't think that's fair. Yeah, but if you can optimize it, nothing like that. Select protocol. I have discussed at least 7 to 10 protocols with you. What do? We do the antagonist protocol. Day 1, day 2, injection, antagonist when lead follicle is 14. Very patient friendly, good outcomes as much as any other stimulation protocol. Secondly, if that doesn't work, we may go to long protocol, or in a select group like endometriosis, adenomyosis, we go to long protocol straight away. Again, very good results. Some papers have said long protocol has better results than antagonist in poor responders. The third is a modification of all the protocols, including Diostim or Shanghai, to see which will be better. If a person has already had these protocols, we may go to Duostin or Shanghai straight away. So selecting protocol is important. Embryo pooling, pool. I really feel if you get a good cohort of embryos and you transfer that good bunch, 2 cleavage stage, first attempt, 3 cleavage stage, grade A, second and more attempts. Your results up. And PRP, infusion in failures, and those who are very, very low AMH, with the disclaimer that it's still experimental. So I'd like to conclude by saying that poor responders need to be treated case by case to optimize their outcome. Duostim, embryo pooling, and PRP are some new modalities. Success rates are still very modest, and we still have a long way to go. Thank you for your patient hearing.